Dear audience, I'm happy to be the one opening this session. My name is Ioana Creanga-Murariu, and my PhD is about cannabinoids in the landscape of cancer. I'm a PhD student in a bilateral program with the Grigore Popa Medicine and Pharmacy University in Iași and the Center for Translational Medicine. My vision is to improve the quality of life of cancer patients, and my mission is to decrease disease burden of cancer patients. I have three specific goals. The first is to investigate the safety and efficacy of cannabinoids in cancer patients. As you know, cancer incidence is increasing, however, the mortality seems to be decreasing, so quality of life is as important as an efficient therapy. The most prevalent symptoms for cancer are fatigue, pain, and lack of appetite. Of course, there is treatment for that, but it can be ineffective for some patients. Cannabinoids are a new class of drugs. Almost 40% of cancer patients admit using them, either physician-prescribed or illicitly procured. Although effective, they raise some issues regarding the proper therapy indication and safety. So our question is to investigate whether cannabinoids are safe and more efficient by comparison to standard of care or placebo for the palliation of cancer-related symptoms. We are going to investigate cancer patients that were administered cannabinoids compared to standard of care or placebo, and we assess the efficacy for the mentioned symptoms, tolerability, and safety. We performed a systematic search in 3 databases using the cancer and the cannabinoid domain, and we ended up with 98 eligible full-text articles. Here you can see a list of all our outcomes. Today I will present you the results for pain, which was measured for advanced cancer patients that were experiencing this despite their opioid treatment. It was measured using the numerical rating scale with 0 meaning no pain and 10 meaning the worst pain. These results come from interventional and observational trials, and we performed a comparison between the baseline and the after intervention pain values. We decided to subgroup the results based on the CBD and THC content of the drugs because these are the active molecules within the cannabinoids. Our results show that overall cannabinoids decrease pain with 1.2 points on this 0 to 10 scale, with the best results for THC predominant drugs. The second outcome is anxiety, again for advanced cancer patients, measured using the numerical rating scale with 0 meaning no anxiety and 10 meaning the worst anxiety. Results come from interventional and observational trials, and we performed the same comparison between baseline and after intervention values, and again the same subgrouping based on the CBD and THC content. Overall, cannabinoids decrease anxiety with 1.3 points, with best results for CBD predominant drugs. We did find some improvement for appetite, insomnia, and chemotherapy-induced nausea and vomiting. However, the results were not statistically significant. On the other hand, we did not find any improvement for constipation, depression, fatigue, mobility, or overall quality of life. Speaking about side effects, the most interesting results were for psychiatric side effects, which included hallucinations, delusion, paranoia, psychosis, nightmares, anxiety, and mood swings. Patients that were taking THC predominant drugs had 10 times the risk of developing some psychiatric side effects. On the other hand, adding CBD to the THC treatment decreased the odds to 2.6. Here you can see a list of all the side effects of cannabinoids. Asthenia and gastrointestinal side effects were the only ones that were statistically significant. Our study has multiple strengths because it assesses multiple outcomes. We provided a comprehensive analysis of every type of cannabinoid with a rigorous methodology. However, the limitation comes from the inclusion of both observational and interventional studies, increased heterogeneity, and do not forget that these were self-reported soft outcomes. We can conclude that cannabinoids have benefits for cancer-associated pain and anxiety, however, with considerable side effects, which limit the usage of cannabinoids in the clinical practice. Cannabinoids should not be prescribed for constipation, depression, mobility or quality of life, because they do not give any positive effect. On the other hand, more studies are needed to analyze their effects for nausea, appetite, and insomnia, because we found a positive tendency, however, not statistically significant, and nevertheless to investigate the mechanism behind the psychiatric side effects. Currently, we are with the internal review part. The second project is to investigate the antitumor activity of cannabinoids in preclinical models. Chemotherapy is still the preferred option for cancer treatment, but it can cause life-threatening side effects. Cancer treatment costs are among the highest in the healthcare system, and sometimes alternative treatment options, sometimes repurposing drugs with other indication can be a cheaper strategy. Cannabinoids have antitumor effect. It has been proven that they can induce apoptosis, decrease angiogenesis or invasion and metastasis. So our question is to investigate whether cannabinoids have antitumor activity compared to controls in preclinical models. For that, we are going to investigate in vitro and in vivo tumor models that were administered cannabinoids with or without chemotherapy and compared to controls. And the outcome will be the antitumor effect, which means decrease in tumor cells or tumor volume. We performed a systematic search in 3 databases, and we ended up with 230 eligible full text. Right now, we are waiting for the first plots. And my third project is to investigate the profile of cannabinoid use among cancer patients. Cannabinoids are gaining popularity for symptom control, keeping in mind that only dronabinol and nabilon are cannabinoid-based drugs that are FDA approved. Medicinal cannabis is not yet FDA approved. And the legal medical cannabis market size is more than $13 billion in 2022. Our aim is to investigate the profile of cannabinoid use among cancer patients. For that, we have 2 question frameworks. The first is to analyze the characteristics of cancer patients consuming cannabinoids, and we will assess their age, employment, education, cancer type, stage, comorbidities. And the second question will be to analyze the particularities of cannabinoid administration in cancer patients. We will analyze the indication, the cannabinoid type, the route of administration, the form of administration. Our hypothesis is that cannabinoid use is dependent on the patient's demographics, and choosing the type of cannabinoid is highly dependent on the form and mode of administration. The clinical implication is that we can prescribe drugs according to the patient's preference, and we can design future studies which support the patient's needs. Here you can see some key articles answering the same question framework as ours, ensuring that our project is feasible. So in summary, I have 3 specific goals, all of them with cannabinoids. The first is to investigate the safety and efficacy for symptom control. The second is about the antitumor activity of cannabinoids. And the third is to investigate the profile of cannabinoid use among cancer patients. Thank you, and do not forget, the harder you work, the more luck you seem to have.
Thank you for this nice presentation. Is there any question from the floor? If not, I have some methodological question. What was the dose of cannabinoids, and what was the way it was administered?
Well, we try to make the most comprehensive study on this topic. We choose cannabinoid administered in any dosage and any form of administration. We were comparing apples and oranges. Of course, you cannot compare oromucosal spray and oral application of the drug. However, we could not subgroup based on these particularities. Maybe future studies will focus more on the particularity of each form of administration and dosage, because we could not draw any conclusion based on that.
And my other question, that in the first study, the investigative group seems to be very heterogeneous. So those patients were all of them on a major analgesic treatment?
Yes, the most prevalent inclusion criteria was for the patients with pain, for example, to have a maximal opioid dosage and to be unresponded to opioid treatment. Not every article defined what unresponding to opioid means, but this is again another limitation.
Do you have any question? Very short one. How do you judge the effectiveness of cannabinoids? So do you use a pain scale, or how was it judged?
Yes, pain was always measured using some type of questionnaire where patient reported that their pain feeling on some type of scale. If it was from 0 or 10, 0 to 100. And we try to convert that scale to the numerical rating scale, with 0 meaning no pain and 10 meaning worst pain. These are self-reported outcomes. Pain was not measured on any type of objective manner.
Okay. Yeah. Thank you. Thank you very much.
Thank you.
Thank you, Anna, for your wonderful presentation. I also have one question regarding the clinical heterogeneity of the studies, because you mentioned that it was like comparing oranges to apples, but still, have you found some specific patient populations or some specific drugs which could just highlight the need for specific studies related to that patient group or drug?
That was our reason for performing subgroup analysis based on the CBD and THC content, because we are speaking of entirely different drugs with entirely different mechanism of action. And we did find, for example, that patients taking THC-based drugs have a better relief in their pain, and CBD-based drugs provide a better relief in anxiety. I believe these were the most important directions when trying to find differences in the responding to the treatment. Of course, there could be more, the mode of administration and the dosage. Unfortunately, up to this moment, we could not perform any more analysis based on that.